morning, everyone. We were just waiting for the gathering. Let's start with World Neuroscience Summit 3, Dysphagia Conference. I would like to invite our organizer, Dr. Govathi Nikhila K, Dysphagia Speech Specialist and Researcher in Dysphagia, certified in VST FEAST MBS, experience of 6 years, published more than 30 national and international publications, received national and global awards as the best dysphagia specialist. Area of interest is dysphagia and research and to develop low-cost instrumentation in dysphagia. Ma'am, please, on the stage.
Hello everyone. Am I audible? Right? So before knowing anything, I'm Govathi. So before knowing anything about dysphagia, I would like to show what is swallowing. How do we eat in our daily life? Okay? Just I'll show you one video.
Swallowing occurs in two stages, the oropharyngeal and esophageal stages. At the start of a swallow, a food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of swallowing occurs in two stages, the oropharyngeal and esophageal stages. At the start of a swallow, a food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent food entry into respiratory passageways. The uvula contracts, which blocks the nasal passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis swings down upon the closed glottis. With all airways blocked off, respiration is temporarily inhibited. As the upper esophageal sphincter relaxes, pharyngeal contractions drive the bolus into the esophagus. The oropharyngeal stage is done and breathing resumes. During the esophageal stage, a primary wave of peristalsis initiated by the swallowing center pushes the bolus through the esophagus. As the bolus travels through the esophagus, the lower esophageal sphincter relaxes, allowing the food to enter the stomach. If the bolus is sticky and adheres to the esophagus, secondary peristaltic waves triggered by the intrinsic plexus at the point of distension completely clear the esophageal lumen to finish the swallow.
देख लिया ना? कभी कोई सोचा है इतना कुछ हो रहा है? We just enjoy our food, right? But internally this is all happening. So then what happens in the patient with neurological disorders? Yeah, called as dysphagia. The patient who is not able to swallow the food or liquid or medicine, solids, anything, if they are not able to pass the bolus from their oral cavity to the stomach, is called dysphagia. So whatever the phases we have seen in the previous video, that is a normal swallowing. So any of the phase can get affected in the neurological patients. If the obstruction or functional mechanism get affected at any phase, that is called. Got it? So we have three phases basically: oral, pharyngeal, esophageal. So what happens next we see in detail. So what happens if we ignore that? ये सब होता है. We get dehydrated, malnutrition, pneumonia, and if we ignore that, it may lead to death also sometimes. So how do you identify it? So whenever we eat the food, if it is getting stuck at the chest, if we are coughing frequently, vomiting sensation हो रही है, या नहीं तो ऐसा बोल रहा है कि गले में ही अटक रहा है, I'm not able to chew it properly or it is not passing down properly, so I have frequent vomiting, I have difficulty with solids, I'm not able to chew it, like weight loss, or whenever they're swallowing, increased wetness in their throat, like changing their voice quality, then this is all like, these are the signs for the dysphagia. If you notice any of these signs, whenever the patient is eating, quickly you have to trigger that there is something wrong with the patient, right? Hope you all got with the signs. Yes, ma'am. What causes dysphagia? Stroke, head injury, spinal cord, muscular. So these are all the functional distinct tumor, COVID-19 also recently because of the respiratory issue, and motor neuron disease. And all these are the causes which can lead to dysphagia and may not help the patient to swallow or enjoy their favorite food. So how severe it is? Do you all know that even we all aspirate or we all have dysphagia? Anyone? कॉलेज जल्दी जाना है तो मम्मी बोलती है ब्रेड खा लो, जल्दी जल्दी खा लो, तो you eat fast and you clear your throat, or you run, you drink the water and you clear your throat. So that somewhere your food get penetrated and then you do that. Food gets penetrated, you clear your throat and you swallow. As we are normal, so some part 11% of normal population will also have dysphagia. And elderly population like 13, brain stroke 70, neurogenic disorders 80, and COPD, HN 70 we have. So this is all evidence based. So I would like to show some video how do patients aspirate. So you have seen normal, you have seen signs, you have learned about what happens if we ignore it. So now let's see what exactly happening
happens when this timing is off. This can happen to even someone healthy and young. This man is drinking soda, but oops, be careful. He ended up choking on it uncontrollably. This has probably happened to you too. This is called aspiration. The symptoms of dysphagia can include choking on food or liquid on a daily basis. Those who have dysphagia have a floppy epiglottis. The food broken down by teeth ends up in the trachea because the epiglottis does not close in time. Or because the swallowing does not take place while the epiglottis is closed. This is what causes aspiration. This is an X-ray image capturing the mechanism of aspiration. You can see liquid is slowly collecting inside the trachea. Trying to swallow, the patient ended up choking. Food and saliva that enter the lungs by mistake actually contain many bacteria and can cause pneumonia if such foreign materials are not removed by coughing or in the form of sputum. Currently, it's estimated that 20% of elderly people in need of nursing care experience difficulty in swallowing. Furthermore, most cases of pneumonia, which is the fourth leading cause of death in Japan, are actually said to be induced by aspiration.
Got it? So in detail about the phases and anatomical part, I think Dr. Prasanna will carry with that. And the radiology imaging, Dr. Ravi will take care of it. So now we all know what is dysphagia, right? What happens if we ignore signs and symptoms? And we have seen how the aspiration is taking place. So what are the types of dysphagia? We have two types, oropharyngeal and esophageal. Because of the neurological deformation, patient could not swallow the food or masticate the food or pass the bolus down and drooling take place or get penetrated in the throat. And this all happens due to the neurological dysfunction, and that is called oropharyngeal dysphagia. If the food is getting obstructed at the chest and he is not able to, if the patient complains that having some burning sensation and he could not swallow and he is getting GERD reflex and bringing out the food, then that is called as esophageal dysphagia. Very good. Be louder. So what are the causes of oropharyngeal dysphagia? Esophageal dysphagia. I think 8 marks in your question paper. Right? 3rd years. So these all are the causes basically which lead oropharyngeal dysphagia and esophageal. Done? So how do you identify whether it is a functional or obstructive dysphagia? If in the motor form, what happens, they simultaneously they may have in a functional dysphagia, neurological, they may have like issue with liquids or solids also. But in the obstructive dysphagia, they have only, they start with the solid, dysphagia will start from the solids, okay, and then progresses to liquids. So who can help to overcome this? You all. Speech language pathologist or a dysphagia specialist will identify the signs and symptoms, and they assess and they plan for the proper management. Clear? Then this is the dysphagia kit. What we have to use whenever we are going to the patient in order to assess or to plan a management program. This should be a basic kit we have to take to the patient side. Okay? So how do we assess the, basically here I'm talking about the neurodysphagia assessment. So here the first criteria is like, the patient GCS should be E4M6. If you assess before that, there is no possibility of clearing the test. So this is the baseline where the patient GCS should be E4M6, so that he follows commands. Whatever I instruct him, he follows, he understands, and then what if in case if I need to train something, definitely he does that. Right? So E4M6 is the first criteria, and then detailed oromotor examination will be done, in which complete oral examination, it is very important, because so that it helps how the patient is masticating, is it supporting or not, all these factors we can check. And then here the assessment is divided into two types. First, non-tracheostomized and tracheostomized. In non-tracheostomized patient without TT, tracheostomy is like without TT. In those patients, we do it like, cervical auscultation will be done at bedside. Okay. In this, we check whenever we offer the food to the patient, we check three phases like oral, pharyngeal, esophageal. But in oral phase, you have to check how the patient is holding the bolus, how is he masticating the bolus, how the bolus control is, and does he has any anterior loss, does he have any premature spillage, is he taking in time, or is he swallowing it very delayed. You have to check in the pre-phase and oral phase. And whenever he's swallowing, you have to see how is he swallowing, whether it is getting penetrated, there is any increased wetness with the increasing food, or there is any penetration. Whenever you auscultate and hear, is there is any increased wetness in his throat, or is he swallowing? Why do we auscultate? I think here we also have some. We auscultate. Why do we auscultate? We auscultate and hear the sound for the bolus quality, how it is transmitting from throat, and also it helps the inhalation, whether if the patient is swallowing during the time of inhalation or exhalation. That is also an important factor to track it out. Okay, so basically during auscultation is a process where we do with non-tracheostomized patient. What we do with the tracheostomized patient, TT patient, we do a dye test, Evans dye test, where we sprinkle like a part of dye in the custard, and then we offer the food, and then we deflate the cup and we offer the food, and then in the suction, this is the green dye color which is showing the aspiration. That patient has been aspirated. Clear? In detail, definitely sir will go. In case after doing the swallow assessment, if in case patient fail or the patient's cough effort is not that good, or we suspect any silent aspiration is happening even though there is no dye or despite dye, or we want to go for some objective evaluation, we have here like fiber optic endoscopy studies, videofluroscopy studies, and modified barium swallow studies. These studies will depend based on the requirement of the patient and the severity of the patient. At that particular, it is not mandatory that we have to go for all the patient only with the fiber optic endoscopy, or we have to go for the videofluroscopy study, but we have to see based on the patient condition and the severity, we take a call what to be done at that point. And if patient fails, and one more thing, in neuro patients, why do we give only the custard or only the blended diet? Because most of the hospitals, most of the doctors, because you go for your internship programs, you go for your training program somewhere, you learn it in your books also, 3 ounce water trial, where we give the water and all. So patient coughs, so swallow fail. Patient cough nahi kiya, to pass hai, to आटी निकाल देंगे, भेज देंगे. This is the concept which we have. But my question for all the neuro, like, neuro team or neuro this thing, if patient cough effort is low, where patient is not, because water is a, like, velocity will be very flow, where we cannot chew the water, so we cannot examine the oral cavity properly. So if we give a water, it just spills out. With the gravity also, sometimes it goes down. That also affects, sometimes they cough and the test get failed. Sometimes they doesn't go cough and that test get failed. So if we give the blended food, we can check all, we can track the all the phases and also see the, it gives an adequate time to us to rule out something. So it is very important for neuro patients specifically to do it with a blended food. So after that, we have a scales, like if patient aspirates, we have a aspiration scale which is grading from 1 to 8. Based on the severity, we give the score. And if in case after if the test is not clear, we'll go for the rice tube incision based on the severity of dysphagia. If in case we feel that patient can eat normally and he comes out of it, we take a NG, and sometimes doctors also insert an emergency basis and then give us a call. And then if we think like, sometimes there's a problem in insertion of NJ, and then it takes longer time for recovery, then we go for NJ placement, and their gastroenterologist will do that. And if we think like, patient with neuromotor disorder and they take longer time, they cannot swallow, then we go for peg insertion. That's a third option. And if the patient clears with the swallow trial, this is a norm scale where we grade the patient's diet part based on the levels, based on the requirement. So these are the levels. We all fit in the level 7, where it's normal. And this is a diet plan where Ms. Sandhya ji is a chief dietitian. She helps us with the diet part. So here we plan the diet based on the patient's result, swallow result. So from level 1 to level 2, the diet part has been segregated. So accordingly, we start with the blended food, liquid diet, and semi-blended, soft and normal, and of course she'll be discussing it in detail. And if patient fails and he's dependent on rice tube, we have a therapeutic management plan where we categorize into 4. Passive perioral exercises where we do at bedside. If the patient GCS is very low and he is not able to follow the commands, so early rehab we start with passive perioral exercises, and oromotor exercises where the patient can understand our commands. So we train the patient with all the oral tongue exercises, and we ask the patient to do on the bedside and also on OPD basis. Swallow exercises and vital stem therapy. It's an electrical stimulation where we stimulate the pharyngeal muscle, and this is like for the patient with the pharyngeal dysphagia and lateral medullary syndromes, posterior circulation strokes, will be getting benefited with this stimulation therapy if we start earlier. And we have some compensatory maneuvers where we do some diet modification, or train the patient with retraining swallow therapy will be done, where we give them some tips or techniques to have a safe swallow. So coming to the decannulation, as I told you, like if the patient is having some tracheostomy, we do a diet test. After clearing the diet test, we start with the diet plan. When the patient reaching 50% of oral intake, with we have certain protocol like with proper respiration, with a proper cough effort, and accepting orally 50%, there is no secretions and chest is clear, then we will take a call and we'll give for a call for the critical care team, which Dr. Dhruv will take a call on this. And then in case everything goes well, they'll come, they'll assess, they'll suggest for the chest x-ray, and then they'll take caller for decannulation. And then this is only a first step. This is not a conclusion that patient is a good candidate for decannulation, but they also check their parameters. And what are the tips you have to follow or you have to give wherever you're feeding the patient or whenever you're training the patient is like, make sure that patient sits in 90-degree sitting position. Do not give solids or straw feeding for the neuro patients for a safe side. And make sure that patient does chin tuck position. Even you're giving a single sip of water, make sure that he sits in 90-degree sitting position. Most of the times attendant doesn't know this, they lie down and they feed the patient actually. बोलता है कि लेटा के दे दिया तो खा लेता है, बैठ के इनको थोड़ा खांसी आ जाता है. These are the questions we have faced. but that is a wrong. So you have to counsel the attendant. So make sure that these are the tips they should follow. Do not talk whenever you're feeding the patient. Do not watch the TV. Stop avoiding. If you notice any cough or respiratory distress, stop. Ask them to stop the food and then ask them to consult the dysphagia specialist or a speech therapist. So this is the dysphagia speech clinic and lab at Medanta, through which we provide a speech and language services from all the hospital on OPD basis as well, and we do a tele-video consultations from here, and it is a lab for a research purpose also. We do thesis and we are educating from internship programs and research programs through this lab. And the dysphagia team is like, I involved with a physician, neurologist, neurosurgeon, and critical care team for decannulation purpose, and the other radiologists to planning any videofluroscopy studies and all for ENT and respiratory team for their respective patients. And the physiotherapist, definitely he helps us to improvise the patient respiratory capacity if he has any issue. And then occupational therapist will help us in feeding procedure, how to hold the spoon and take it to the mouth, not on the dysphagia part. And the dietitian, of course, definitely for the diet plan and the management. And these are the services which we provide from our dysphagia clinic, like we standardized custard and dysphagia evaluation for non-tracheostomized and dye test, and videofluroscopy, fiber optic studies. And the therapeutic management involves the sensory vibratory stimulation at bedside, passive exercises active, and vital stem therapy, speech therapy, and academics part. So these are the evidences, researchers which are IRB approved, in which we are stating that in fact patient get quick recovery comparing to bleed patients. And we have done, this is of course a delay paper, actually lateral medullary 250 cases. Recently it come to the 490 patients we have seen lateral medullary. And if we start on the day 3rd, the therapy of vital stem therapy, if we give on day 3rd, definitely they will get recovered on 7th or 10th day of their stroke. So there is no patient there among 490 patients. Almost all the patients are accepting orally. 2, 3, hardly 2 to 3 or below 5 and 10 only patients they are, because of the bilateral stroke. They could not recover fast. So then there is also a paper showing that early swallow rehabilitation helps the patient to overcome their dysphagia, and also that prevents the aspiration. I cannot attach more papers, and these are the references. Thank you everyone. Any questions? अरे क्वेश्चन नहीं पूछना है. चलो, I welcome Prasanna sir on the stage, and Muskan. Sir is having 10 years of experience in dysphagia, and he started his lab, and he works with SEC. And take over. Thank you, sir. Thank you for coming here.
Raja.
Dr. Prasanna has is a onco-decutology and other certification courses founding secretary for Society of Feeding and Swallowing Disorders. He is also a coordinator in Indian Speech and Hearing Association Dysphagia Special Interest Group of International Dysphagia Diet Standardization India Initiative Reference Group of members. He has experience of 9 years in onco-rehabilitation, neuro-rehabilitation, and clinical establishment and innovation. So please honor the stage.
Thank you very much for inviting me and introduction, and also wonderful crowd. So I think it is my first talk in Delhi, so I'm excited about the crowd as well. So I don't have much time. I have just 20 minutes to cover up the dysphagia assessment and treatment in the nutshell. And some of the things which I'm going to tell is a little overlapping to already the master who's sitting here from Medanta. And you should all have a visit to her clinic or her hospital and check out what are the things that can be learned from there. So I am Prasanna Hegde. Just a moment. Yeah. Sorry. Yeah, so we are looking at assessment and treatment of dysphagia, especially in terms of protocols about what to do in neurological setup. And I would have loved to cover all the things from medical history till interventional assessment and beyond. I'm going to look at assessment and treatment as quickly as possible without wasting much time on what are the reasons, what are the patient perception. So it is going to be only clinical. I'm not going to ask patient that how satisfied they are. There's nothing like that. There's just clinical about what I do with the patient and my understanding. So the basic stuff about anybody assessing is about how you feel the patient and how the patient responds to your commands and other things. So clinical swallow evaluation, anything, any other clinical setup in any other medical field starts with a clinical evaluation. So you first observe the patient or ask the complaints and do a specific evaluation, which everybody is aware of. What you make sense of those things is something which comes with wisdom, which is again learned from practice and making mistakes. So don't get scared of making mistakes. It's all the regular curve of learning. So we would look at cranial nerves, oroperipheral examination, voice, cognition, pulmonary health. So Govathi has already spoken about how important it is. Knowing the subsystem is very important. I know it is very exciting to say that I am a dysphagia specialist or deglutologist. There are a lot of science behind that. A respiratory therapist, a neurologist, an ENT surgeon or ENT specialist, everybody is important. Even the F&B people, food and beverages people, how they understand my communication is also important. So I am not the only one who's handling dysphagia, and especially in a multi-specialty setup or a hospital setup. If I have a clinic, it's okay. So I can do my own job because I'm cutting cost. But if I'm in a setup where there are a lot of other specialties, and I might as well use their services as well. So we generally look at having an SOP. I was just having a conversation with other specialists here that we are moving from physician-centric approach to a patient-centric approach. Now, it's not that physician feels like referring or it's identified as a problem. So we just generally refer. Now, if there is a problem identified, you can start with screening and then go on to discharge them whether they require any services or not. So this is the general understanding of how evaluation should happen. So this does not require any instrumentation or any infrastructure. All you need is a table and chair and a willing patient who will converse with you. That's it. You cannot say that I'm not a dysphagia specialist because I don't have fees or videofluroscopy. You can do with a lot of things. Just pen and paper. Pen and paper is not just for literacy. It's for dysphagia as well. So there are standardized clinical swallow evaluation. So there are people who have established these things. So this is the list of things. One of the example is GUS evaluation, and it also requires a lot of standardization if it has a local or cultural background or socioeconomic background. So you can look at how well standard evaluation can fit in your clinical practice. So you need to understand what clinical practice you have, what is the clinical caseload you have, and what is the aid that you get from these clinical swallow evaluation. You cannot just pick up somebody says that okay, this is good, that's why I'm using it. That's not how it works. It is about your comfort level. If you can perform better with just the unstructured or informal assessment without using a standardized one, I think you are the boss. You can decide on those things. Does not look at, okay, I need to publish a paper, that's why I need to use a standardized one. Okay. Yes, it's a cherry on the cake if you want to publish a paper, because nowadays it's perform, publish, or perish. This is what the general trend is. All right. And you also have to look at what it gives. It has to be sensitive. It cannot be just doing an interview. You don't have to fill a lot of pages. Okay. You have to make sure that in the half an hour you have with the patient, you get as much as possible. If not enough with the patient, just go back to reports and check. All right. So now starting with the first thing. So dry swallow is something which is very important for us. And there are 3 tests which can be done together with the dry swallow. Dry swallow is nothing but saliva swallow. You can do 4-finger test, and which is established by the legend in dysphagia, that is Jerry Logman in 1998. And also you can do repetitive saliva swallow test, which means that repeat the dry swallow as much as possible. Although in neurological patients it is relevant, it will also be sensitive for fatigue and progressive neurological conditions where you look at number of swallows and the interval between the swallows. Although the normative is little fishy, 3 times in 30 seconds, I think even some of the dysphagic patient also can do that. Okay, it has to be customized based. Now, how degrading that is going to be in terms of task. That means today the patient was doing 10 swallows in 30 seconds, and tomorrow and after a week they have reduced it. So those things also we need to look at. And there are a lot of factors about saliva presence, whether there is xerostomia, excessive saliva, or what time of the day you are doing it. All those things are very important. So you understand whether there is instances for swallow or not, whether I have to really go ahead and do other tests or not. Okay. So next one is water swallow test. So water swallow, there are a lot of variations. You can do it with ml, ounces, cc, and all those things. So there are a lot of studies which says that every test has different kind of recruitment in terms of why it is required, or engaged in terms of what is the need for us. How much is too much is one of the paper which is published for various reasons. And the first and the last one, again, it talks about 100 ml water swallow test and factors affecting. Based on that, you have to use it. And just because you have 100 ml and do it, this doesn't make sense. And there are also indexes which can be calculated based on the speed with which the water is swallowed and the amount per swallow. All those can be checked with all those things. So not necessary you will be able to do 100 ml water swallow always. Sometimes you will just restrict to 5 ml swallows, multiple swallows. So modified version also available. Now what are you going to do with that is something which you need to look at. A lot of studies have done in terms of sensitivity, and you need to look at how well it indicates whether it is unsafe or safe. You should be worried if this test says the patient is safe for swallowing. If it is unsafe, you already know, you anyways go ahead and do more tests. But if it is pass, swallow safe, then you need to be worrying whether it is really true or not. If you're wrong, then you're going to have an emergency. And you can use cervical auscultation with all the above tests. You just have to either listen to it or record, and then later on listen to the sound and analyze using Pratt. And these are the different stages of swallow. Inhalation you get, exhalation you get, and you check whether what kind of acoustics are there when the exhalation of exhalation post swallow happens. If it is gurgly or any disturbance in breathing out, then you know that there are certain residue either in the piriform sinus or in the vestibule. Okay. Color water test is a famous thing about Evans blue dye. There are modified Evans blue dye as well, and this is used either in tracheostomy patients or in total laryngectomized patients. Again, the sensitivity again differs, and it might indicate that there is aspiration, instances of aspiration. And there are different methods. Now if you use a supracuff tracheostomy tube, then you know that how to check the events. You just have to use a syringe to take out the secretion through the suction port. Otherwise you just have to wait for the patient to cough and take out through the tracheostomy tube, or you do suctioning. Anything is fine. Just that you have to take the risk assessment, not that it's a confirmatory whether patient is having dysphagia or not. Okay. Now if this is positive, again you are happy that you anyways going to do more tests. If it is negative, then you need to be worried. Is it only for this consistency or any other consistencies that is going to be affected? Okay. Now to instrumental evaluation, everybody gets excited about fees and videofluroscopy, and then I would say that if you do this just the video recording and try to make a report, and it is useless for us. And instrumental evaluation is not just to identify aspiration or penetration. It is beyond that, and your dysphagia is not just till that. There are a lot of other things which needs to be looking at. And safety. When somebody talks about dysphagia, why do you want to go to or become a dysphagia specialist? People say that, no, I feel excited about all this instrumental evaluation, which is wrong. Which I say that it is just 10% of our clinical practice. Somebody not able to chew is much more than somebody having aspiration. Okay. All those things are important. Now, why I kept this one, this various things that can be tested. The first picture is the contrast getting stuck at the PFS and post-cricoid area because of the obstruction. Second picture is a normal picture where bolus hold is there. Now you're going to look at dysfunction as well as functions. Okay, and in the video fluoroscopy, you will be able to even assess about what is the bolus for, also about cavities. Now, cavities are important because some cavities need to close while swallowing, and some cavities needs to remain open and transfer the pressure. That is when peristalsis happens. Okay, and the last 4 pictures, that is the fees pictures, which talks about different consistencies. First one being just the saliva, the second one is liquid, third one is thick liquid, and fourth one is the paste consistency or semi-solid consistencies. Okay, now over this we are going to discuss about why we choose this. Now I would just say, if it is available, try doing it 100% of the time, and then you have your own wisdom, because you're doing injustice to the patient. You're doing simply just because it is there, and you develop your own skills of making decision skills, because you should understand that there are a lot of students coming in for training, right? They also need that capacity building. Although you know that it is not required, the patient needs that, the students needs that wisdom as well. Okay, need not go to all the pros and cons of these things. If it is available, if you think it will help in more understanding, do it. Okay, but on a serious note, video fluoroscopy will tell you all the 3 phases to some extent, and video fluoroscopy gives you a realistic expectation about pharyngeal dysphagia, not oral, neither esophageal. Okay, so if these scales are not put onto that, then the videos are all waste. Okay, penetration aspiration scale, the original one and modified one. Modified is more sensitive or more statistically sound, and the second about saliva comments and the bolus residue comments. All those things are important now, because we are going to make decision on choking for saliva versus food penetration and also aspiration. All of them are different. Okay, you need to understand whether you're going to scale those saliva choking on penetration aspiration scale or not. You should have something different. Now, second scale, again, this is dynamic imaging grade of swallowing toxicity. This is originally for radiation therapy toxicity testing. You can still use it for objectively measuring the videos, and both for fees as well as video fluoroscopy, this has been standardized. Fees has got standardization recently. Okay, so it talks about safety and efficiency, which is very important. Okay, residue also will be checked, just like how other Yale pharyngeal residue scale and other things will be doing. So this is a scale which is very easy. The multiple scores are there like a matrix, and you'll be able to score those things. Now this is the residue scale, which is again important. It is a it requires training. You have to buy this one, but still you'll be able to make some understanding based on the publication that is there. Okay, and you have to comment about what kind of residue and how much is the quantity. If you don't do it, then there is no outcome measure that you're really tracking. Okay, and these are the scale. And there are residue leading to aspiration as well, that is delayed aspiration. It's not immediate, or it's not before the swallow. It is after the swallow aspiration. That also needs to be commented, because previously all the scales, they don't mention anything about timing of aspiration. So with the barium swallow, you can actually look at the barium swallow bolus residue scale, which can be used on video fluoroscopy. You have to again compare those things with laryngeal examination as well, to see where exactly is it bilateral, because in the video fluoroscopy you may not be able to really comment about what is the quantity right and left. Okay, so esophageal manometry, which generally comes in the purview of a gastroenterologist, which will comment about motility of esophagus, although it can be modified to check the peristaltic motion from the soft palate till the upper esophageal sphincter. You just have to modify or place it at a different level and validate those positioning as well. Okay, and if you have a willing gastroenterologist, go and check with them if they can do. I think Narayana Health is going to try one of the scientific publication on that. One of my good friend is here who's going to look at establishing normative as well. So now there are scales on which again you look at outcome measures. food intake level scale, which is a generalized dysphagia things. It is not valid for head and neck cancers because there are a lot of clearance issues in head and neck cancers. It can be used directly for neurological patients. Okay, it's very easy to use. Already Govathi and talked about it. But if you are using swallow therapy and want to understand those things as well in terms of oral intake, you can use one of the scale developed in Japan, which is called FILS, food intake level scale. I'm not sure why it has not come out of Japan. There is no publication out of Japan. So it's actually good with even addition of speech therapy. Okay. Why this is important for neurologists? Because there is faster clearance for neurological disorders for speech therapy than any other disorders. Okay, head and neck, we have to wait. I work in a tertiary setup for head and neck oncology. I have to really wait for 3 weeks to start even saliva swallow sometimes. Okay. So this is the scale, functional oral intake scale. And this is just an example about how I have developed for head and neck oral intake. So it's just about saliva swallow, sips of water, which is again dependent on the team as well, how they have trained. Sometimes they start with liquid, sometimes they start with banana, and it again depends on what kind of training you have from which center and what group they're working with. Okay. So now at the end, you look at interventional assessment, which technique helps. That also needs to be done with instrumental evaluation, and also whether it alleviates the problems or not, or whether it improves the functions or not. Okay. So you can look at whether posture helps or not, consistencies, quantity, endurance, when the patient gets tired, temperature, what temperature helps in the slightly warmer temperature helps in improving the opening of upper esophageal sphincter, and also texture, better sensory response, and rehabilitative approach with prosthetics and maneuvers also in combination of all the other things. Okay. Now quickly moving on to other aspects which is also important: airway edema, airway passage, secretions, glottic chink. All these are important things. You need to comment about those things as well. Okay. Now this is another thing which probably can be looked at from a physiotherapist angle as well. Lymphedema things, generally relevant more for head and neck cancers, but again it is important. Not necessary that person will have only neurological or head and neck. It can be both. There are many patients who commit stroke as well as post-op for oncology. There is another thing, New Zealand secretions severity scale. You can quantify the secretions as well. Okay. Now looking at rehabilitation, we would like to start with something which is very important for us, breathing, which will also help us in swallowing as well as decannulation purpose, and all the other aspects. Overall health also is important for the patient. So you can look at ambulation. Ambulatory patient aspirating is much better than bedridden patient. I would be happy to send them home, if they are ambulatory. Okay, and these instruments can be used to train expiratory muscles and clear the secretions as well. You can also look at oral or enteral nutrition. Govathi has already mentioned about. If it is long term, it is better to go for PEG tube rather than put the nasogastric tube. Or if you think it's short term, then go for nasogastric tube and as quickly as possible go to oral. So this is again, clinical nutritionists should take the call on terms of all the aspects, whether they are losing the weight, whether we are taxing the patients or not. Again, our role becomes backbenchers in that, or backseat for that. So we generally start with compensatory first, if clearance for oral is there, because we want to make sure that patient feels happy about some success, because adherence is important. If you think that without any success, ask the patient to keep doing the exercises, patient will be lost. We want some success at the beginning itself. So that is what we mean by passing the dysfunction or bypassing the dysfunction. Use all the strategies for airway safety and positions. So we'll come to that. And facilitatory first, if there is no clearance. If you have not got any oral clearance, you would look at facilitatory approach. You can use that to improvise the normal physiology, general care, exercise-based therapies, dry swallow, and all the techniques which does not involve any food items. You just have to play with the exercises. And facilitatories can continue when the clearance is there with the compensatory, because that is also important. Okay. Now, oral and tracheostomy care, that's also important because that can be a site of infection which can lead to pneumonia, which then generally physician says that aspiration pneumonia, which generally says that don't give anything oral. Now you've gone back to square one. And you have to make sure that all those things are taken care with other team as well. Now the strengthening, all the oropharyngo, laryngo, motor exercises can be done even without clearance. Oromotor exercises, pharyngeal exercises like Masako Manyo, mouth opening exercises, Shakir's exercise for releasing the or strengthening the upper esophageal sphincters, and small transfers for kids or in any neurological patients where high lift can be done. All exercises can be done, in combination with any other techniques that you have. Okay, so this is very easy to do in neurological patients. This is much more relevant. All right. Now Mendelssohn's, this is what happens. The vestibule closes. This is one of the strengthening exercise again. Okay, you have to make sure you strengthen the suprahyoid muscle so that while swallow happens, it is lifted well with good strength. Okay, this avoids the during swallow aspiration or good clearance because of the good opening of upper esophageal sphincter. Okay. Posture, another compensatory technique. You can turn the head, you can tilt the head, you can have combinations of it. You're only changing the vector of food which goes to the pharynx. You would like to avoid the airway and move the bolus towards the piriform sinus and upper esophageal sphincter. And in oncology, we are okay if the patient sleeps and drinks. That's the safest thing for us. Yeah. So safety and efficiency, again, opposite things. But neurological things you have to really look at, what is safe and what is. So we also have to look at cultural aspects as well. And chin down, chin tuck, again, it is a debate about which one to use. What happens when chin down? Chin down is for bolus control. Chin tuck is to make sure that the pharyngeal constriction happens, there is less area, and then squeeze happens proper. All the physiological things that happens with the techniques you need to know. Assistive devices can be used. Again, you need a prosthodontist or fabricator. Consistency modification. Again, you need the FNB and the physicians, and very important is the clinical nutritionist. Okay, these things needs to be standardized. I am happy that you have standardized the curd consistency. It's very important for us. Now this is a standardized one. I'm not going to go in detail because there are other speakers who are patiently waiting for their time. Sensory approach, textures, temperature, all the things are very easy to use it with good information about how it works. And at last, I think this is the famous strategies which we look at. Now, why do you use supraglottic or why do you use supraglottics? Now, if I am focusing only on airway safety in terms of clearing the bolus from the airway, then I only use supraglottic swallow. But if there is increased residue in the piriform sinus or valleculae without having any aspiration, I would use effortful swallow. But if it is both aspiration as well as residue, then I would like to use both supraglottic swallow plus effortful swallow, which is going to be supraglottic swallow. How long can I use it? After every swallow, you try today, go back home after every swallow, cough, and you will know the pain. So as early as possible, your physiological approaches have to be kicking in, and you should be weaning off these compensatory strategies as well. Right, so with this, I thank you for the opportunity to present about assessment and management, which is very important, but without the team, interdisciplinary team, I cannot function. I might as well resign from the hospital and go, because hospital is a place where coordination is important. It's not multidisciplinary, it is interdisciplinary because everybody has their role. It is not replaceable. Not like oncological where chemotherapy can work in some patients or surgery or radiation oncology. No, everybody has their own role without having any kind of conflicts of interest. So thank you.
So I have a question
Yeah.
for you.
Sure.
In the auscultation, you
showed a stat which is getting recorded. You asked that like we have to record and you can hear it later. But here in the neuro cases, what we observe, even whenever I auscultate, I can feel that he's having silent aspiration, or it is getting penetrated, and it may lead to delayed aspiration and all by hearing the sound and all. But here, when I train my students or show it to them, I cannot describe the sound which I am hearing. So if you have that can be recorded, is that designed only for HNC, or it can be used at?
It is general. It can be done for everyone. Yes, you just have to connect the suction catheter tube to the microphone, and microphone connects to the laptop, and the other end of the suction catheter can connect to the chest piece of the pediatric stethoscope.
So does that have any noise barrier? Because
you just have to look at what kind of filters you're using, and you will get a signature of various stages of that swallow. Acoustic signatures.
So do you do that in a Pratt software?
Yes,
or
Pratt
software you will be analyzing it?
See, if I'm left alone, I will function well. But my responsibility is to train others as well. I am not scalable unless I train others.
Exactly. Because now here what I'm hearing, I can differentiate it is because happening with respiratory or gastritis or neurogenic dysphagia. I can differentiate. But here when we auscultate, but sometimes the respiratory factors also get affected. We cannot rule it out like why it is happening. So how do we differentiate this?
Actually, you can look at the modification of 100 ml water swallow test.
So, but in neuro patients, we cannot go even with the liquid trial. We give the high chances of aspiration are there.
You can look at voice. You can look at voice as one of the things. So phonation before and swallow. Phonation is possible. There are methods where you can look at. You can look at closing the tracheostomy tubes, and you can look at pre-swallow breathing. There are a lot of acoustics already happening. You just have to standardize those things for that patient. You cannot have a group which will give you good signatures where you standardize those things. But on a patient-to-patient basis, you will always get something which is common or regularly happening, which probably makes sense for you. It's a patient-to-patient basis.
So this you are using at patient side also.
Yes.
I'll discuss in detail.
Sure, definitely.
Thank you so much, sir. Thank you for honoring. So I welcome Dr. Dubey, sir. Thank you for honoring here. Dr. Dubey is a neurosurgeon. Thank you, sir.
See, we have seen rehabilitation of the muscles, this swallowing, everything change. It changes outcome of people, and it really makes a difference between a fast recovery, no recovery, and death. So what we are discussing today is very important, and especially in our neuro patients, and the debilitated patient is very important. And this meeting is very important because, see, we cannot get all the patients in Medanta. All patients will be everywhere. Education is the key. Making patients better is key for increasing our profession. So with that, Govathi has been doing a good work for us for a long time, and we appreciate her contribution to our hospital and to the people for educating. So that's very important.
Actually, thank you so much for supporting to organize this workshop. Because of this, so many people here gathered. I think they are really getting benefited out of it.
I request Dr. Dubey to.
So can you
Dr. Prasanna, Dr. Govathi. Next presenter is Dr. Sonal. She is Associate Professor in SLP, Bharati Vidyapeeth School of Audiology and Speech Language Pathology. She is not well, so she'll join us in virtual mode.
Good afternoon, everyone. I am thankful to the organizers, Ms. Nikhila and WNS organizing team for inviting me to share my clinical experience about aphasia assessment and rehabilitation. I'm sorry for the inconvenience with the poor health. I could not come in person and present. I hereby have my recording on the same talk. I hope to do justice. So, welcome to WNS Aphasia Dysphagia workshop. I really congratulate Nikhila and the team for taking up very important topic, which is often missed in terms of assessment and rehabilitation. Am I visible? Are my slides visible? Sorry for technical errors. So, in ocean of aphasiology, there are many knowns and unknowns. So it's very important in Indian aphasiology. We understand language in human brain, different linguistic areas in left hemisphere and right hemisphere, dominant person and predominant premorbid. What are the person's abilities, education, cultural aspects, the reading, writing, calculation abilities, literacy, or the functional literacy and musical abilities. So, with that, every person with aphasia is pretty different to respond to your aphasia rehabilitation, and it should be client centered intervention and assessment also in terms of diagnostic and rehabilitative workup. So, as a physiologist, what I would like all of you to first understand is screen speech, language, cognition, and communication and everyday life skills at bedside and the person's premorbid and current abilities. So it is important that we have adequate tools which can help you understand neurocommunication disorder in whole. So a typical connected speech picture communication tool assessment would help you identify if the person has dysarthria or apraxia, aphasia, or plus agnosia and amnestic syndromes. So majority of time we see at bedside dysarthria is highly prevalent. But where there is a dominant hemisphere damage, the person may have aphasia, which could be non-fluent or fluent, or it could be mixed fluent. So one needs to understand the incidence and prevalence of neurocommunication disorder, post-neurological disorder, like stroke, traumatic brain injury, eloquent cortex tumor or neoplasm, epilepsy, neuroinfectious diseases, dementia, and neuritis syndromes. So, in our Indian scenarios, be it city or rural background, I see there are very few SLPs available, well trained in aphasia, catering services at bedside because of many constraints. So, we need to really improve our the rehabilitation team and equipping the many hospitals having a complete SLP team in neurology and neurosurgery who can be dedicated to screen all the patients at ward and adequately provide the therapy which can curb the mobility and disability with respect to communication. It could be alarming, burdening numbers in Indian scenario. However, we have very poor research coming up because of many constraints again. So there is so much of aspects we can do. So treatment gap needs to be really filled with timely identification and adequate rehabilitation. Are you providing acute care to a ward to the return to work rehabilitation in all the patients who have difficulty in speaking or reading or writing or calculating or remembering or all are in one patient? That's very important that you SLP needs to really get trained and identify the patient and follow up the patient. So many of the patients lose to follow. So why? What are the important factors? You can still work on a hybrid sessions at few face to face and few tele. I'm sorry with my poor health, I'm slightly feeling dizzy. So you need to advocate and educate medical professionals, allied healthcare professionals, your role of SLP at critical care, high dependency ward for aphasia, dysphagia, and cognitive assessment and rehabilitation. neurosurgical ward, not just post-intervention, but pre-surgical workup is also important, helping the person with eloquent cortex tumor, understanding that what are the risk factors he or she will develop. And before that, you have to do some exercises which are going to be helpful for him and that will give him confidence. So, preparing someone developing at risk of aphasia, developing aphasia would be helpful. So, you need to have a workup for the DBS, eloquent cortex tumor neoplasm. So, as SLP, you play a dynamic role in identification, assessment, and intervention of aphasia and related neurocommunication cognition disorder. Without memory, be it semantic memory or phonological memory, episodic memory, communicative abilities will suffer. So language and cognition goes hand in hand. So it's important that how to assess and intervene cognition and communication in a person with aphasia. You play a role as a case manager because the person and family members, caregivers of the person with aphasia, come to you from the day 1 or day 2 is stable at the ward and when they get discharged, but there will be continued care required, unlike a neurologist who would make the patient come after 3 months or 2 months. But you have to encourage them that rehabilitation medicine is importantly to be followed up in the hybrid session. So how the patient is improving versus regressing or not improving, educating the family member, and the change roles in the same teacher or same homemaker, a mother who was managing whole family and talking, singing, chanting, managing so many communicative complexities gets non-fluent aphasia or a fluent aphasia. It's different. So you need to advocate, to educate. So there is a research needed in aphasiology in India that which approaches really work, which approach may improve with some other approach or techniques. So there is so much to understand in person with aphasia. Living with aphasia can be very depressing in our talking world. So you need to understand that. So you need to screen person with aphasia with respect to understanding the cognitive status. Use simple mini ACE or MOCA, Montreal Cognitive Basic tool, which is utilized for the illiterate population where the reading writing is taken up. You can even use the simple semantic association tool, is non-verbal in nature. So is patient able to understand, carry out simple commands? Is he speaking simple words? Is he able to repeat one word to two word to phrase? Is he able to name simple objects? So that's important that you need to screen. I'll take you around with some test material in Hindi aphasia population, which you, majority of you audience here, see the patient in. So there is a Francia aphasia screening test developed by ICMR Neurocognitive Toolbox by Professor Allari and the authors. There's Western aphasia battery and Hindi diagnostic tool available free of cost in ICMR and AISH. So that could be helpful in majority of people who work in aphasia population. You need to have standardized, valid tools in literate and illiterate population and the norms. So you need to understand aphasia in a person as a whole in spoken, written, and gestural modality. With that, we do have to understand musical abilities. I love to sing, listen to music, and what makes me happy is some nice songs or chant or artis. So we all are somewhere connected to the divine. So be it Hindu or Muslim or Christian, any person in India. So when you cannot communicate or read or chant, it can be disabling. So it's important that we understand at bedside that is he or she able to chant, that could be preserved. And how about prosodic abilities? So musical abilities, prosody, can be screened at bedside and it can be given as an adjunct therapy, which could be helpful in motivating a person. communication for swallowing is very important. So all of us work in swallowing rehabilitation. I congratulate Nikhila and the group for having dysphagia and aphasia, both workshops to be taken today. So patient is able to swallow his saliva or not? Is she able to say that he or she is not able to swallow? There's some food stuck in the throat or going in the wrong way, or she has a fear of choking. Is he or she able to follow your commands when you are screening or diagnosing, evaluating the swallowing skills? Cranial nerve function. So swallowing and communication is very important to be understood. Someone who doesn't follow your commands because of the aphasia or the non-fluent or fluent difficulties with neurocommunication abilities, one should understand that how you can give rehabilitation of dysphagia with simple cues or simple pictures, or importantly, the safe swallowing therapy should be modified in the person with aphasia, dysarthria, or severe apraxia in terms of buccofacial phonation or lingual apraxias. And when the person has aphasia, it causes much more heightened morbidity. So you need to have holistic assessment of person with aphasia, what etiology he or she is presenting with, what is the age of presentation. We get to see children with a pediatric stroke or ileocean cortex tumor or autoimmune encephalitis, where the person may present with aphasias. It could be mild to moderate. However, vascular aphasias are high in prevalence, whereas dementia, Alzheimer's disease, or primary progressive aphasia, cerebral dementias, are less identified because of the poor equipped knowledge and training. So you need to really advocate the role of SLP in dementia workup with cognitive linguistic abilities and the rehabilitation across advancing stage of dementia. So I will take you across the neurogan.com by Professor Dr. Pauranik, where you can find out simple exercises, home-based exercises for aphasia therapy for Hindi population, as well as good developed valid tools for aphasia screening diagnosis. Yes, so search for neurogan.com/aphasia and you can download Hindi aphasia screening test, HACCP, Hindi aphasia brief indoor battery, or full aphasia battery, or reading writing indoor battery, which are phenomenal in terms of helping you understand the person's abilities across modality specific language skills. There is a LibQ questionnaire also, and these tools can be utilized by the SLPs. However, there is need to develop and utilize communication checklist and communication based therapy task, which could be helpful in understanding how do you communicate everyday needs at bedside or at chairside. And many times the aphasia quotient does not greatly improve, but communication quotient, which is seen in the FCP or ASHA FACS, can be improved. So search for Communicative Effectiveness Index, CETI, or FCP or ASHA FACS, or ASHA NMOS, Outcome Measurement Scale, which could be really helpful for each of you, which can be easily administered at bedside, mid-therapy, pre-therapy, and post-therapy to understand how one patient with aphasia with neurocommunication disorder is improving, not improving, or regressing. So there are different stimuli, resource material available about aphasia in this website. Have a look at it and feel free to utilize. So it's important that we understand every person with aphasia is different, be it a 2 ladies with the same lesion and similar age or education perspective. But what is the lost versus preserved abilities across modalities could be different as per the reserve in the person with aphasia. And the stroke intervention has does play important role. And person who is identified with stroke and given adequate intervention early, the time window, the person may have less disability. So time matters. Fast, FAST. So all SLPs need to educate common man about why two person with aphasias are different and why one may respond to one therapy technique when other may not. So altered pathways, reorganization of language and cognition is different. So one should understand the etiology, then the factor influencing the cognition and language in aphasia. So one case, SK was a retired teacher presented with early morning irrelevant talk, sluggish gait, not able to see, could not make her tea. There was long-standing hypothyroidism, no previous significant history except the COVID healed. SLP was given call at 3:30 when patient was neurologically stable.
मी आलिश कोर माझं नाव वसुधा माझं नाव वसुधा आहे. विशाल वसु माझं नाव वसु माझं नाव वसुधा आहे. म्हणा लिंबू चावी कंगवा कंगवा.
You could see her naming is affected, repetition is affected, auditory comprehension is affected. She has a fluent speech. However, it's important to understand what aphasia it is. Is it aphasia? This is a lesion she presented with. There is a right hemisphere and left both side lesion. This is a wake-up stroke and the fluent aphasia. What test you should carry out at bedside? You can have French aphasia screening test, Hindi, or you can do bedside aphasia VAB. You can utilize aphasia bank protocol and the checklist from CCABI to understand the pre-therapy, mid-therapy, and post-therapy needs of the communication. Let's see next case vignette. The 64 years homemaker in 19 presented with loss of memory and difficulty in getting correct words. Family members neglected her difficulties and got to a neurologist only in 21, and she was sent to me in 22. Good ADL, everyday skills. She can still cook, but she can't talk, hold conversation like earlier, which she enjoyed. She can't read, she fumbles for the verbs, and otherwise healthy. So her MRI is this. You couldn't get her PET scan or the other CSF studies. So look at her connected speech, cookie theft, discourse, narration. She says, Dada is doing something, he will fall. Water is spilling everywhere, water now. Yes, boy is getting laddu, mother is not there. So there is a fragmented telegraphic speech, which is unlike Broca's or transcortical motor aphasia, not that non-fluent. So progressive aphasia with a degenerative pathology needs to be understood that they are still non-fluent, and there's a progressive non-fluent aphasia with or without apraxia of speech. However, their comprehension is much better than any other Broca's or transcortical motor aphasia. Their fluency is much better and communicative intention also, but there is added emotional liability and difficulties piling up when the person understands that he or she is not greatly improving. So this was her writing abilities. So you can see the Sylvian Fisher atrophy. There's a grammatic variant PPA, which is also called frontal lobe PPA, phonological variant BPA. She has good visuospatial skills. She is not logopenic variant. She has preserved anterograde memory and semantic memory, so she is not semantic variant or logopenic. So there is PPA non-fluent, which is PNFA. So one should understand that if you don't have the adequate testing, but understand the fluency, comprehension, naming, everyday communication, and differential diagnosis could be helpful in understanding the person with aphasia with the A from network with the person's activities and participation and the communication needs and current abilities. Personal factors with the person with aphasia and the caregivers, body function, and the quality of life in person with aphasia. So in acute stage lesion phase, the goal of evaluation should be helping the person with communication disability, getting the picture communication board, pointing, helping the family member accept the person with aphasia and changed he or she, and then still helping him or her communicate without mocking or laughing at him or her. Chronic stage, yes, comprehensive assessment and comprehensive rehabilitation can be carried out and understand the improvement versus regression or there is a plateau. So goal of the aphasia rehabilitation is to inform the patient and caretaker that what aphasia is and it requires a rehabilitation medicine. Many patients ask me क्या कुछ दवाई हो सकती है ये लेकर बात कर सकते हैं हमें लगता नहीं है ये एक्सरसाइज आप जो दे रहे हो पसंद नहीं आती है इन्हें करने के लिए so when I tell them that see it's a behavior talking is behavior so you have to work on your everyday language communication abilities as a therapy and then you'll get to see the person improving across modalities so not just stroke or etiological based medication but rehabilitation is going to help you so it goes hand in hand rehabilitation medicine and pharmacological surgical intervention which needs to be educated across the continuum so one should understand that then the second goal is to appropriately choose the techniques or approaches at bedside therapy. Sorry, I'm feeling dizzy. And you need to train the conversation partner. Do's and don'ts about communication to reduce rate of speech. Speak in simple language. Don't switch to L2 or L3 post-stroke or post-neurological morbidity. The patient regresses the second language or third language. So maybe he or she may not be that fluent like earlier. So helping him or get rehab, but speak to him or her in a simpler way is important. Use pictures, gestures will be helpful. Oromotor exercises, intelligibility of speech, cognition, communication, everyday exercises could be helpful. So the third goal is to encourage patient caretaker, I would say even medical professionals, that they inculcate the good value in the persons with aphasia that they have to come for therapy. And many times when there is no great follow-up, then the person may lose the interest and the rehabilitation may take backstage and the patient may not get adequate improvement. So societal attitudes change communication performances and the person's current abilities do matter and you have to really help the person with aphasia and the family member that it is not aphasia which is big, it is the person with aphasia who has been earlier a doting dad or a daughter or a son and very importantly he or she requires to be respected communicated cared so we need to work understand that does speech therapy really improve person with aphasia yes there are many rcts which say no therapy no great improvement. With a formal therapy, yes, there is improvement. So, pattern of clinical recovery in aphasia can vary person to person with the very different patterns with the age, lesion, localization, and the brain which is responding to therapy. So, it is important that we chalk out and understand the cognitive, communicative rehabilitation. There are different approaches in aphasia. So, I would tell you that use specific treatment approaches along with technology, apps, everyday simple skills of non-verbal tasks to help him or her gain confidence that he or she can do certain tasks. And when the person can match, when he doesn't have to listen or talk, it gives him confidence that no, he can do. And later you can have the rehearsal. So repeat, and point and recall could be helpful. So there are cognitive linguistic approaches which will be helpful. AAC in aphasia is very important, which to be considered. So low tech AAC, which is pantomime, gestures, picture communication board, to the high tech AAC where you have avatar based therapy and the app can speak to you. You need to understand aphasia therapy. It's different in different people, so we need to have a tailor made therapy. So there are many different researches from evidence-based therapy in aphasia. So they say that class 1 evidence is high intensity speech language therapy in acute subacute phase have so far only been given or less efficacy if you can read very early verse trial versus 2 hours every day 5 to 7 hours a week therapy could be really beneficial and helpful. And they have discussed that the transcranial direct current stimulation TDCS or brain stimulation could be helpful in chronic aphasias, whereas early acute stage the behavioral medication therapy could be helpful. So there are different factors affecting aphasia, its pre and post therapy outcome, and he or she, whoever is person with aphasia, how he is improving and how you have to consider different strategies. So aphasia therapy improves quality of life and you have to encourage person with aphasia take face-to-face or hybrid session considering major fluency, comprehension, and the lesion localization with respect to helping the person's family members connect with him, not having him isolate. The optimal dose for therapy in aphasia is 2 hours daily versus 4 hours daily, one study. But 2 hours daily in Indian scenario, I don't think so we can afford to take therapy. However, 2 formal sessions a week and other days, actual weighted articulation, speech, language, naming, reading, writing, communication activities could be helpful. The drills can help you. That person has been improving in the modality based therapy. So it is important that we consider person with aphasia as a whole, and every patient is different. Not all the Broca's or transportal motor aphasia are good prosodic and auditory comprehension and the prosodic perception. So they may not yield or improve on MIT. So rhythm matters. So there music can be used as adjunct therapy. However, you can utilize cognitive linguistic verb naming, semantic feature analysis, VNest, and the everyday communication based task ILAT intensive language therapy, which could be helpful in person with aphasia using biopsychosocial approaches. So, Aphasia and Stroke Association India, we are committed to help person with aphasia and their family members and professionals. You can read the information about stroke in different languages, aphasia information, and we will be posting workbooks free of cost, which can be utilized and given to the persons with aphasia and caregivers, which they can utilize, and you can guide them how they can utilize certain tasks and practice at home. There are simple worksheets available there. It is not substitute for speech language formal therapy, but an adjunct to your speech language formal training, which can be given at home. So Professor Pauranik has developed home therapy based resource material in aphasia, and few of the assessment tools can become therapeutic. So you can utilize the picture to word, picture to sentence in Hindi and English. So cognitive behavioral therapy improves person with aphasia. Everybody needs to communicate, connect to the world and society. So one should not deprive the neurological disorder population from talking, reading, writing because of the want of rehabilitation. So we need to understand the bilingual of the therapy really importantly work. Bilingualism adds advantage. So there's important theory which says Indians are at good cognitive advantage with executive functions and language abilities. So encourage bilingualism, assessment of aphasia, and therapy also. Thank you.
Now I would like to call our next speaker, Sandhya Pandey, MSc in Food and Nutrition, PG Diploma in Population and Health Management, Certified Diabetes Educator, General Manager and Chief Clinical Nutritionist in Medanta, the Medicity, Gurgaon. Please welcome. Yeah. Over to you, ma'am.
Thank you so much for that nice introduction. And I know I can see a lot of you getting restless now because it's a Sunday. And let me thank you all for being present here on a Sunday. And that itself is showing your commitment about learning and understanding. And I try to be very brief because thankfully the best part about being third, fourth in the presenters is that a lot of things are already covered. So I don't have to talk about dysphagia per se in this group, but I thought that I'll bring your attention towards why we are talking about all this. Finally, why at all do we have to talk about, ability of a patient to eat the food or swallow it, and why is that going to be important? And when I talk about that, we have to understand malnutrition. So I hope that all of us understand that malnutrition is extremely important to understand, and the prevalence of malnutrition after stroke, and especially because neurological disorders is a huge array. So we kind of focused on stroke because stroke is something wherein dysphagia is common, and you need to look at dysphagia right from the beginning till the end of the journey of the patient. And the prevalence is very, very common here. There are various systematic reviews which have been done, and they say that malnutrition can be prevalent ranging from 6% to 62%. And there's a lot of problem there because most of our neurologically ailment patients cannot stand. Now, the most important thing in assessment of the patient is you have to weigh the patient. Now, this patient can't stand. So how are you ensuring and finding out that the patient is losing weight? What was his weight? So that makes the assessment of the patient a big challenge. So this is a good study, and this was a systematic review and meta-analysis which was published in year 2021, and which basically said that impaired nutritional condition after stroke from hyperacute to chronic phase. And I am actually going fast forward, and you can see that the percentage goes as high as 72%, and one would say that, oh my God, the patient is pretty much all right. But you see, even after 6 months, the patient's risk of malnutrition and impaired nutritional condition is as high as 72%. So that means the malnutrition is really, really prevalent in stroke patients, and we need to worry about that. So what are the risk factors? The risk factors would range from history to physical examination. And you would see if your patient goes without saying, the patient is elderly, if it's a woman, if the patient has existing comorbidities like diabetes, hypertension, polypharmacy, and of course, a previous history of stroke, for that matter, depression, antidepressants that the patient is on. That is one aspect of the history that we all need to understand would make the patient more prone to malnutrition. And then the physical examination. So if the patient has a reduced level of consciousness or patient has reduced mobility, swallowing difficulty, we've been talking about that. One of the most important factors is dysphagia, which is a major risk for malnutrition, and it predisposes the patient to more than 2 times for malnutrition. So that is why we are here talking about dysphagia, because we have to find ways of mitigating those issues about swallowing. Okay, now dysphagia, and like Dr. Govathi has already spoken about, what does dysphagia do? It will cause dehydration, and it is estimated that about 62% of stroke patients suffer from dehydration at some point of their admission. And there can be multiple reasons. A lot of times patients are simply afraid of drinking water, probably because they're afraid of choking and the amount of coughing that they have to do. And dehydration is a potential cause of DVT after stroke. So dehydration is one of the predictors of poor outcomes, including discharges to long-term care. Now let's talk about mechanism involved in risk for aspiration. Now we all understand that dysphagia is going to cause dehydration and malnutrition. How is this impacting your aspiration and pneumonia? If the patient has malnutrition, the patient has a loss of muscle strength. The loss of muscle strength will cause the patient's inability, and the patient will not have cough reflex. That will cause lower capacity to remove the aspirated material. So you would probably be too worried about dysphagia. I would be worried about malnutrition. We both will have to work together if we have to prevent the patient from pneumonia. On the other hand, if the patient has dehydration, the patient will have oropharyngeal colonization, and the positioning and various other factors are going to predispose further the patient to the risk of pneumonia. And that is something that we all are worried here. So why talk about malnutrition? Because malnutrition has clearly indicated that there are adverse outcomes related to malnutrition. So you have to handle everything else because you want the patient not to be malnourished right from the time of diagnosis till the time the patient is discharged and till the time the patient goes out of the hospital. So this is a very recent study. Again, third China National Stroke Registry found that malnutrition risk in ischemic stroke patients was linked to higher risk of long-term death and major disability. So we are talking about fatal results starting from adverse outcome to mortality of the patient. And there are high rates of pressure ulcers, respiratory, and UTIs. This was again another good study which was published in 2022, as recent as February 2022. And they, in this case, they actually studied the risk of mortality in ischemic stroke patients treated with intravenous thrombolysis. And they also finally concluded that malnutrition may be associated with higher risk of mortality in 3 months in ischemic stroke after intravenous thrombolysis. This is again a very famous study, food study, which is quite old but still very relevant. And it said that malnutrition can have a higher impact of pneumonia, infections, pressure ulcers. And certainly, as the longer the patient stays in the hospital, the risk of malnutrition and the chances of hospitalization, rehabilitation, mortality rate, all of that increases. So coming to the common point, why are we talking nutrition now? Everybody here is talking about dysphagia. Everybody here is, speech language pathologist and everybody. So why do we even have to talk about it? So nutrition support, how does it come? Now, this eating is the most important thing. If you don't eat, obviously the patient, or for all of us, we would not get nutrition. So the very basic component of nutrition is ingestion. You have to eat, and then the food has to go into your tract. So for the nutrition support, there are 2 essential factors that has to be done: nutrition screening and dysphagia screening. I think a lot of us are missing the dysphagia point. Now we actually, and I think that's something that you have to take home from here, because in hospitals we do have nutrition screening and nutritional assessment as a component in our hospitals. But is dysphagia screening happening? I really do not know. In my hospital it does happen, because we are a good hospital. Medanta Hospital has protocols made for all our neurological patients and stroke patients. So once you do the screening and assessment of the patient, you will have to identify whether the patient is malnourished or not malnourished, patient is dysphagic or not dysphagic. And all this will decide how we are going to take the journey further. So if the patient is malnourished and not dysphagic, even then I will have to get into the picture. see whether the patient's intake is all right or not, give oral nutritional supplements, all of that. But if the patient is malnourished and is also dysphagic, the problem is big. Here we will have to think of enteral nutrition. And again, like my previous speaker said, that we will have to see for how long the patient may be dependent on a tube. We will have to decide whether we have to do nasogastric or we have to do a peg placement. Now, one would say patient is not malnourished. Do we have to bother? Yes, of course. If the patient is not malnourished, still, if the patient is dysphagic, we need to think about that. What do we need to do? And that is where the texture changes come into picture. Dr. Prasanna before me and Govathi was also talking about food. And we'll have to, the screening of dysphagia will have to start from there. If the patient is not malnourished, not dysphagic, even then we'll have to keep monitoring because we don't know how the patient is progressing when it comes to nutrition. Now, who all are the candidates for nutrition support? How many patients are actually? So we need to really screen our patients. So those of you who do not have dietitians in your setup, you can use a simple screening tool. And this screening tool can be done used by any nurses available or maybe doctors. And there are the basic 3 questions. If the patient's BMI is less than 20, or the patient has lost weight in last 3 months, or the patient has been eating very less in the last 1 week, or has the patient been severely? Any answer to any one yes comes yes, that means the patient is at risk of malnutrition. In that case, we need to refer the patient to a dietitian or an expert, a clinical nutritionist, and there then we do a detailed assessment of patient. In our assessment, we would have to ask, how is the intake of the patient? Has the patient been losing weight? What are the various comorbidities of the patient? What is the age-related comorbidity? All of that is clubbed together and a scoring is made. And accordingly, we then plan the nutrition care accordingly. Now, certainly, I don't have to talk about screening tests for dysphagia here and all of that. Now, once we have done the screening and assessment for both of the factors, then we have to see what does the patient need to have. The nutritional intervention happens. Now, a lot of times what happens is the dysphagia assessment and screening is not done. Most of the times the doctors would keep telling us, khilao, khilao, khilao. Patient to kha nahi raha hai. Now, we do not know why the patient is not eating. The patient is having difficulty in eating, and that's the problem. So how much, how and when and what is the question that as a dietitian I need to answer. And we have to then see what are the short-term goals and long-term goals. Of course, when I'm talking about short-term goals, my goal is to ensure that the patient has. Now, all of you, I have this challenge when I talk to my experts, my doctors, and other experts. Kha raha hai, just kha raha is not enough. Kitna kha raha is also is important. So if your requirement is 1800 calories and 80 grams of protein, and just having 500 calories and 20 grams of proteins, do I intervene? Do I do something about it? Is the question. So my goal is to ensure adequate calories, proteins, micronutrients, along with hydration. Because the patient is afraid of eating and he's not able to achieve the entire swallow mechanism, we are failing. And just ability to take down that food is not enough for me. So I will certainly have to be confident that my patient is able to get the required nutrition. So all of that is my goal. And for you all to know, and I think all of you must know, that the requirement for a stroke patient or neurological patient, or for anybody for that matter who is hospitalized, 25 to 35 kilocalorie per kg body weight. If the patient is, and we have to calculate ideal body weight adjusted, but broadly you can understand that. So 50 kgs, 15 to 30 is that much, 1800 kilocalories is the requirement. 1.1 to 1.2, or it may go as high as 1.5 if the patient is geriatric and the patient has other comorbidities. Fats, vitamins, minerals, vitamin D, and I'm not going into detail for the simple paucity of time that we have. Texture is something when it comes to stroke, I'm worried, and that's something which is the mainstay here. For my patients who are not dysphagic, who are not malnourished, I would not give oral nutritional supplement unless there is an indication. So ONS is not. So a lot of times what happens is when the patient is not eating, you say, isko protein powder khila do, isko supplement khila do. Please understand, the supplement is only supplement. It is not supplementary to food. So as a dietitian, we need to actually assess how much is the current oral intake, how much is the requirement, what is the deficit, and how do we go about it. That is what we need to do. Now we have something called European Society of Parenteral and Enteral Nutrition, which gives us guidelines, okay? And this is a huge text, and if you are interested, you can actually read this. It's a very simply written format, and it covers every aspect. So whether it is medical management or everything related to you. So here there are recommendations, certainly, and I think we've established that all the patients who have dysphagia, they should be screened. So the stroke patients must be screened. And in the screening, if the screening is, found to be negative, obviously we'll have to go ahead with a formalized assessment. Texture modified diets and thickened liquids may reduce the incidence of aspiration pneumonia. So which means that it is established, there are enough studies and researchers to say that if the patient has dysphagia of any degree, we will have to think of texture modification. Every stroke patient who receives texture modified diets or thickened fluids should be referred to special nutritional assessments. So we need to actually calculate how much is the patient having. Texture modified diets and thickened liquids may lead to reduced energy and food intake. So you would say, ठीक है, custard तो खा रहा है, सूजी खीर तो खा रहा है, हो रहा है, but वो कितना खा रहा है? If it's 1 spoon, 2 spoon, invariably my patients are eating less. Even if they don't have dysphagia, my patients are eating less. Please understand, all my hospitalized patients, I'm struggling to feed them with or without dysphagia. So here there is an added problem that has come into the picture. So in stroke patients diagnosed with thin liquid aspiration-free access to water in addition to thickened liquid may be an option for thickened liquids alone. So we really need to understand all of that. There are some recommendations given for tube feeding, and we will have to think of tube feeding if our patients are not in a condition. So like Dr. Govathi said, there has to be an assessment and tube has to be placed as soon as required so that we do not lose that golden period, because in ICU, the patient is losing muscle mass. And you all are physiotherapists in speech language, you understand the importance of muscle. If the patient has sarcopenia, muscle loss, this patient is probably going to be on ventilator for longer period of time. The patient stay is going to be more. So we will have to ensure that we quickly put in. There is also this myth about NG feed. And a lot of times my patients say that if the tube is put in, I would not be able to take in anything. So that myth will have to be clarified. And it is established that NG feed does not worsen dysphagia. Hence, dysphagia therapy should be started as early as possible. Now, this was the functional oral intake scale that I find and very, very useful. And for this, I certainly depend upon my experts in my hospital, wherein we have to actually, the levels are given by our SLPs and Dr. Govathi in our case. So level 1 to level 7 and level 1 to level 3 is tube dependent. Level 1, very clearly, you can't give anything. These patients are tube dependent. Level 2, tube dependent, you can attempt some amount of feed, and majorly it is semi-solid. Level 3, you are pretty much 50-50. Level 4, you can start giving oral a single consistency, but in that case, we will still be looking at the intakes. So that is how, and I'm going to in our subsequent. So you can probably look up this paper also. And in fact, this is the reference given below, Carrie. And it is a very good paper that you can look at, which will give you, if you guys can want to go back and look at it in your hospitals, respective hospitals, you can put it as a protocol. And this is the protocol in Medanta that we follow, wherein if the patient is level 1, of course, the patient is on RT feed. If the patient is on level 2, what we do is we say we can only give these, and we have standardized our custards, because consistency is a very challenging thing. Now, me and Dr. Govathi has had so many arguments on just the consistency of custard, and we actually had to sit with our, chefs to ensure that, the custard is certain consistency. And not just that, if you keep the custard outside at room temperature, it will become thin. And if you keep it in the refrigerator, it's thicker. So I have to give this custard the certain consistency just at the time when you want to do the swallow assessment. So it's very challenging. So liquids, milkshake, thin custards, thick soups, semi-solids, plain custard. So pretty much we do most of our assessments with our custard, which is kept in the pantry of our floors. So we have neuro floors and wards, wherein in the pantry we've kept it. And as soon as my expert comes into, speech therapist comes, as soon as Dr. Govathi comes and she asks for it, is the time when we give them. So in level 2, we are giving just 30 ml, 2 small spoons of this, and see whether the patient is taking or not. And this swallow test continues to happen at routine intervals, because not necessarily on day 1 the patient passed or failed, you would not want to do it. When the patient goes on to level 3, we continue RT feed, and here then the number of solids, semi-solids that we give increases. Mostly we give semi-solids only, and preferably custards, and maybe sometimes patient gets bored with custard, so we give thick suji kheers or stewed pureed stewed apple, pureed papaya. These are some things that we can, but we have to ensure that the water, it has to be cohesive. It should not be something that the water and the solids are separately hanging differently. Now here is the challenge. As soon as my patient is, now my speech therapist says normal, the patient is able to have, things are going fine. And the moment this is said, the patient is anyways in a hurry to get rid of the tube. We do not let that happen. We will have to tell the patient to continue on the feeds, on the solids that we give and semi-solids, and preferably these are the kind of things that we say about 6-8 times. And we do not give anything through the tube. We see how much is the nutritional intake of the patient and accordingly decide on giving a nocturnal tube feeding, and probably give some oral nutritional supplement to ensure. Understand that in all the levels, my calorie and protein targets have to be met. Level 5 is a stage better, wherein probably now we can think of not giving any tube feeding, but we still do not remove the tube. And in level 6, we are in a safe zone. By and large, we can give a soft diet, things which are chewable. These are, not really pureed, but we can give softer foods that the patient can have, and easy to digest. And by this time, the patient is probably getting discharged, and we probably would not have to. And the patient comes for follow-up on level 7, wherein the patient is by and large eating everything, and there are no problems. Please understand, under all circumstances, the dietary monitoring has to be kept. We have to ensure that the nutritional intake of calorie, protein, vitamins, minerals, all that is happening. We have to modify route, consistency, and there can be a lot of to and fro. One would say कि नहीं अभी खा रहा है. Maybe we'll have to go back to level 2 and say, no, it's not working because the patient intake is not sufficient. Fluid balance, GI functions. Some patients complain of constipation. Some patient complains of loose motion, diarrhea. We have to keep a check on labs. We have to check sodium, potassium, electrolytes, blood sugars. All of that will have to be checked. Long-term goal, paucity of time. Please understand, stroke patients, they have a tendency of being malnourished later on also, even if they've started. So I know your job's finished once the patient, is eating all right. But my job doesn't finish, because I have to ensure that the patient doesn't get stroke again. The patient's functionality doesn't go down. The patient is not deficient in any nutrient. The patient's blood pressure, blood sugar, cholesterol, weight, all of that is maintained. And if the patient is geriatric, I might have to think of oral nutrition supplement. So the long-term goal also have to be kept in mind, and we have to counsel the patient that all of that is important. Now, Dr. Prasanna did talk about the International Dysphagia Diet Standardization Initiative. I think it's a wonderful initiative where all of us use the same terminologies, because within the organization, the terminologies are different. What I'm calling thin is not thin for you. What you're calling thin, what is pureed, what is blenderized. And I think we all can take back this, and and there is a full PDF, as to how do you test the consistency. So if you use a syringe and say 4 बूंद गिरे हैं तो ये thin है, 6 बूंद गिरे हैं तो thick है, that kind of definition has been given. So please take this back, and wherever you're working in a bigger hospitals and setups, get in touch with your dietitians. I think the dietitians and the dysphagia specialists or SLPs have to work very closely, because they can be understanding. We all have to understand what are your challenges or what are my challenges. So my challenge is always ensuring that the patient eats sufficient amount of food, eats sufficient amounts of liquids. So this is something that we need to, and this is an NHS hospital which is actually very clearly defined what level is what for them. So this again you can get very easily online. So in summary, nutritional treatment plan tailored to the specific needs of patient can help meet energy needs, prevent weight and fat loss, also contribute in important functional status. We must assess the risk of dysphagia as well as nutritional malnutrition right in the beginning, using proper tools. Formalized screening for dysphagia. Thankfully, in bigger hospitals, we have that. Medanta, we have a full-fledged protocols. But I think when you go back from here, you can also look at making very simplified protocols in your hospital. Further, and it is not one time thing, you have to continuously monitor the patient. So on day 1 the patient is X, how does the level of the patient is going? Of course texture modified diets will have to be done, the dietitian will have to keep monitoring everything, and multidisciplinary or interdisciplinary team approach is strongly recommended by all the institutions. Thank you so much. I'll be happy to answer any questions if there are. I hope I did not exceed my time limit. And thank you, Dr. Govathi, for giving me this opportunity to come and talk to you all. Thank you.
Thank you so much. It's a wonderful presentation. As we all know that it's getting delayed, we are out of time. So there are 2 lecturers left out. And I also request every student, there's a hands-on session going on. And there's a dysphagia kit which has been displayed. So I request everyone, the professionals who are working and the students, to go ahead and participate in the hands-on program, because you don't get the chance, you go see what is happening, so learn what to do. There is an eye tracker, there's an fiber optic endoscopy, and there is a VST mission, and dysphagia kit was displayed. So go to the exhibition room before leaving, check out for that, and then you can leave for the day. So we left out for the 2 sessions. I invite Dr. Dhruv to come on to the stage, sir.
Good afternoon. I'll not spend too much time on me. Let me see my lectures.
Just can you do it now? Sorry, Dr. Dhruv, just give me a second.
Okay, sure.
As we are going down to the time, there is a group photo. So I request everyone to gather here. Everyone. Shift wise, you people can go and see. We'll be sending you by 5 students or 10 students in this sequence. Please come back, take your seats.
You are actively involved in tracheostomy care. Can I see some hands? कोई है जो tracheostomy care कर भी रहे हैं? Means I might just be speaking. But are you actively involved in that tracheostomy care or something? Or for that matter, ET tube? Anyone? Can I see the hands, please? Okay. So tracheostomy is a common procedure. We generally see patients of stroke, traumatic brain injury, and in neuromuscular disorders. So these patients generally they need prolonged artificial ventilation. Then they are not able to maintain their airway independently. Sometimes the secretions comes into play, and they are not able to expel out those secretions voluntarily, or there might be some surgery also because of polytrauma. So in these patients, we do have these tracheostomy in place. So before going for the care, we should need some idea. We should have some idea regarding the types. Can be single or a dual cannula tracheostomy tubes. Can be fenestrated. Can be cuffed. Can be uncuffed. Or in short necks or in patients who need longer tracheostomy tubes, we can have those tubes also. So fenestrated tube, why it is important? It may be considered for patients who are undergoing weaning from ventilation, because they can facilitate speech and reduce the work of breathing also in compared to these non-fenestrated tubes. So in these tubes, there are 2 types of cannula, one with fenestration to promote airflow and speech, and the other without fenestration for suctioning. So I will come to that later on. So how we go about caring for the tube? So number 1, basically there is inability to communicate because sudden lack of speech, the patient might become conscious, and then suddenly they realize I am not able to speak, or they might be having some difficulty of swallowing, as sort of outlined before. Then they demonstrates significantly reduced life satisfaction and body image perception even after decannulation. So what I say is basically they need a great amount of moral support with regards to communication even when they are tracheostomized, so that they can be successfully decannulated or cared for. So how we go about the caring? So we have to control the infection. So number one, we have to be absolutely spick and span, so to say, sort of prevent the control by having everything in a sterile manner. Alcohol gel or hand washing before touching the stomach, gloves, and for changing or a tube or a dressing, the gloves has to be sterile. But for suctioning, clean rather than sterile can also do. Aprons and eye protection obviously is required. Dressings, the site should be assessed once in every 24 hours for trauma, infection, and inflammation. You generally have the tracheostomy tied with a tracheostomy tape, so the back of the neck is also important. We have to see for it for signs of redness or inflammation. The skin around the stoma can be wet because of secretions or infected, so can apply some barrier dressings. Then we might need to change the holder as well as the dressing if they are frequently soiled. So number one, most important, it is a two-person technique. Do not go around doing it by a single person because it can cause dislodgement leading to severe complications, even loss of life. So red excoriated or exuding stoma should be swabbed, and the doctor on duty or the neurophysician, whosoever is involved in the ICU, he should be informed or she should be involved as early as possible. And most importantly, you are dealing with neurocritical patients. We have to have some venous drainage. So the tracheostomy tube holder has to allow for 2 fingers to fit under the holder, both sides. Otherwise, there might be impedance of the venous drainage. So the inner cannula, if the tracheostomy has an inner cannula, it has to be regularly inspected approximately 4 hourly to prevent narrowing, and ultimately it can cause a blockade of the tube also. So depending on the secretion, you might need to clean it frequently. Non-disposable, it has to be cleaned according to the manufacturer's instructions with sterile water and air dried. And a study by Zoring et al., they have said that cleansing the inner cannula with a detergent is at least as effective as cleansing using an alcohol chlorhexidine solution. But if you do cleaning with a detergent or an alcoholic chlorhexidine, be very sure to dry it or at least clean it with sterile water. Otherwise, it can cause inflammation. Oral hygiene is very important. 2% chlorhexidine gel, mouthwash, regular mouth care, daily assessment of the buccal mucous membrane to note for bacterial, viral, or ulceration. Conscious patients has to be encouraged or assisted to maintain their oral hygiene using a toothbrush, toothpaste, and intermittently doing some gargling also. This is important from the viewpoint of them basically swallowing and eating their food also. Sometimes all this ulceration can also be a constraint in taking the food. Subglottic secretion, drainage, and cough management. Basically, the tubes generally nowadays we get supraglottic tubes to suck out the secretion that is collected over the cough. That has to be meticulously done. Humidification, very important. Why? Because you bypass the normal airway mechanism for humidification and warming of the gases. This will increase your mucus secretions viscosity, diminish the ciliary function, and ultimately leading to the increased risk of infection. So most important, you have to maintain systemic hydration. That's wherein your nutrition kicks in. You have to have adequate enteral and parenteral fluids and feeding. So how you go about humidifying these ventilated patients? If you have loose or no evidence of secretion, the SMA filter that we put in the inspiratory circuit is good enough. we have to replace it every 24 hours, or if it is getting contaminated by the collected secretions, we have to replace it earlier than 24 hours. Thick secretions, you can use saline nebulizers or N-acetylcysteine. Difficult to clear secretions or evidence of consolidation in the x-rays, which you do in a regular basis. In these patients, you have to replace the HME with water humidifier and consider mucolytics like N-acetylcysteine. Self-ventilating patient requiring oxygen therapy or not requiring, if they have thick secretions, saline nebulizers can do the trick, or difficult to clear secretion, then again you have to bring in the mucolytic. Now, should we install normal saline to facilitate sputum clearance? It can be harmful. So instead of it, humidification and saline nebulization is considered and should be considered. Weaning, basically you can go about by cuff deflation, glove finger occlusion, decannulation cap, downsizing the tube, use of fenestrated tube. I will not touch on this. I will go for the one-way speaking valve, how we go about it. Speaking valve trial is one of these initiation of decannulation, whether or not they can do it. So we have some one-way speaking valves which can be used very effectively in tracheostomies and ventilator-dependent patients, which you find in plenty in the neurocritical care. Use of one-way speaking valve is dependent upon the patient's ability to tolerate cuff deflation. So cuff deflation is the first step which we have to sort of see whether the patient is able to tolerate it. So what are the types? We have a Portex orator one-way speaking valve, which we use in our hospital frequently. It has a one-way mechanism. The valves open on inspiration, allowing the air to enter the airway via the tracheostomy tube. But then during expiration, it closes. So now the air has to go into the upper way and larynx to allow for phonation. So this is how it is sort of functioning. Passive Muir tracheostomy and ventilatory speaking valves, we are not using it, but we have these speaking valves for patients who is on ventilator dependent and can tolerate cuff deflation. So where we do not use it, inability to tolerate full cuff deflation, that's obvious. Airway obstruction, unstable medical and pulmonary status, laryngectomy, severe anxiety or cognitive dysfunction, that can be common. Anarthria, severe tracheal laryngeal stenosis can be common in traumatic cases or end-stage pulmonary disease along with some neurological disease. How to go about it? You monitor the SpO2. If the patient is conscious, self-ventilating, you have to explain the procedure. Non-fenestrated tube, the cuff must be deflated and the inner cannula has to be removed. Humidified oxygen is required, then you place it over the speaking valve. Once the speaking valve is in place, you have to ask the patient to breathe in via the tracheostomy tube and blow out gently through the mouth. So these are the things how to go about it. The figure on your left is the incorrect way out, and the right it is the correct way. So you do not leave this cuff inflated during exhalation. So trial attempts of phonation by asking the patient to say ah or cough or 1 to 5 counting. Automated speech such as counting is easier than spontaneous speech. If the patient voice is gargly or wet, then ask them to cough and clear the secretions. Now, if any during any stage the patient has respiratory difficulty, SpO2 level decreases below 90, fatigue sets in, or the patient requests it, then you have to remove the speaking valve. So passive Muir, I will not touch it, but you have to LAD anxiety, look for evidence of airway patency and ensure the minimum ventilator support, pressure support of 15 with a PEEP of not more than 8 is adequate, and all the vitals should be under normal limits. Cuff deflation, basically deflate the cuff, airflow at mouth, we have to check intolerance, any evidence, we sort of reinflate the cuff and do not proceed further. If the patient is tolerating cuff deflation, then we insert that valve into the ventilatory circuit, assess the ability to phonate, and again as before, any vitals compromise, SpO2 decreases, distress, no supraglottic flow, hoarse voice, inspiratory stridor, request of the patient, we do not go further. So gurgly voice, again have to ask them to cough and clear. So with dysphagia, how we arrive at a decision to decannulate and liberate the patient. It's a complex process. We have understood it by the previous lectures. I will not go into it again. So timing has to be means appropriate. Spontaneous breathing reachieved indefinitely, respiratory tract reduced, and the chances is reduced, and efficient cough is there. Then we sort of think about it. It cannot be performed always, although it is important in patients with severe brain injuries. Cannot be decannulated as early as possible. Or if they go this decannulation trial, they has to be repositioned. So before decannulation, we have to see the anatomic patency of the airways, the effectiveness of the defense mechanism like coughing. He has a good expulsive cough, and the patient has the ability to manage oropharyngeal secretions and swallowing, which again is dependent on the patient's conscious level. So he has to be absolutely E4, M6, VT. So that is the phase when we can absolutely go for a decannulation. Prolonged artificial feeding, it always obviously can disrupt the complex interrelation between deglutition and respiration. That can cause impairment. Hypopharynx, larynx is often shared by this, so that can aggravate the dysphagic phase. So the tracheostomy tube, they have its own sets of creating it trouble in the sort of the whole axis from the larynx towards the laryngeal muscle, the esophageal muscle, the reflex mechanisms, whatever the subglottic, the supraglottic areas, they can cause a whole set of trouble by itself. So decannulation protocol, you have to have a protocol for this. For successful, the evaluation has to be combined with a pathophysiological study of the respiratory function. The respiratory function has to be good along with a good swallowing thing. So the alteration that can be altered during the, you can encounter this in the oral preparation of swallowing. So reduce lip closure, limited jaw movements, lip cheek, two-third sensitivity disorders, and all the tongue movements and the soft palates movements, forward movements, they can all be compromised and causing sort of impediment to your decannulation plan. So these are the alteration that can be encountered in the pharyngeal phase, the soft palate failing to close, then some asymmetrical pharyngeal movements, then the laryngeal movements are reduced, then the laryngeal closure obviously will be incomplete if we see it through a laryngoscopy, then the upper esophageal sphincter dysfunction. All these again can cause a sort of impediment in the pharyngeal stage. The saturation level has to be there over 92 in breathing room air or oxygen supplementation in COPD patient. Need for mechanical aspiration like significant secretions and frequent aspiration is a relative contraindication. Protective reflex, whether or not they are produced by spontaneous or tracheal aspiration, the intensity we have to see it. Productive cough force of over 160 liter per minute with adjuvant techniques like mechanically assisted cough is in favor of decannulation. Effective cough, if it is not present, is a contraindication for decannulation for obvious reason. X-ray anomalies, pneumonia, infection may contraindicate decannulation. Fibrobronchoscopy can see and assess your vocal cord mobility and tracheal patency. Vocal cord paralysis in adduction will obviously, we cannot decannulate. Capping the uncuffed cannula with SaO2 monitoring, that shows your ability to breathe through his and own glottic plane. Indirect information about the tracheal patency. The monitor SaO2 is good enough, more than 92, you can go ahead. So we don't have too much of guidelines, but then the Italian Society, they have published a guideline in 2010 where they have given a statement on severe acquired brain lesion. It is recommended to proceed with decannulation in subjects with a suitable level of consciousness after clinical assessment of tolerance to progressively longer capping of the cannula. So if the patient is tolerating the capping of cannula, the tracheostomy, for at least 48 consecutive hours, then you can think about it along with the other criteria. What are those criteria? Saturation more than 92%, effective cough with ability to manage it on self, no infection, no abnormalities in the x-rays, and partial swallowing effectiveness as evidenced by the rehabilitation team, absence of obstruction from the upper respiratory tract, and nutritional condition is satisfactory as per your dietitians, then we can go ahead with the decannulation. Evaluation of oral, nasal, and pharyngeal secretion, the cuff tracheostomy with deflated. Then we see the spontaneous management of secretions, and then the SpO2 variation or respiratory symptoms. So how we go about it? You color the secretion, the saliva with methylene blue. You do it twice a day. During that time, you see you did the SpO2 monitoring. If the secretions is coming out with desaturation, or there is recurrent infection in the respiratory tract, we keep the cannula cuffed and abandon the weaning protocol. Swallowing test, we do it, and then we see this ability to swallow fluid, then we go stepwise, swallowing fluids, they are able, then we go for semi-solid, then we go for solid. So we can take this sort of flow chart. Tracheostomy, we deflate, do a methylene blue test, the secretion is there, inhaled secretion, desaturation episodes, or there are some respiratory complication. We stop the protocol, maintain the cuff cannula, no more decannulation. C for dysphagia, if the patient is dysphagic, postpone till the potential dysphagia resolution is there. Methylene blue test, we do no secretion, no desaturation, no respiratory compromise, do a swallowing test, non-dysphagic, do decannulate. So in vegetative patients or minimally conscious patients also, if they show a reasonable effectiveness of cough and spontaneous swallowing, despite being in that state, we can decannulate. So severity of the clinical and neurological state, they can obviously have a significant influence on your decannulation failure. But then if you have a multidisciplinary approach, then we can go from a mission impossible where we can make it I am possible. That's my message. So if you have a multidisciplinary team, get everyone involved, we can be successful in managing this patient as early as possible. Thank you. Dr. Ravi will get you a little bit radioactive with his lecture next.
Good evening, everyone. So I'll be talking about the radiological evaluation of dysphagia. So it's a VFSS, which is also called as Videofluroscopic Swallow Study. Is a dynamic radiographic evaluation of oral cavity, pharynx, and the cervical esophagus. We just screen the esophagus, but it's predominantly the cervical esophagus that we do the imaging for. And it's again, multiple people are involved, which include speech language pathologist and the ENT surgeon who understands the dynamics and contribute to the therapeutic strategies. Our main role is to identify the structural abnormality and the disease processes. Coming to the VFSS protocol, so oral agent is a barium that is used. And rarely when the patient is either allergic to barium, we use a non-ionic water-soluble contrast media, which is iohexol, but that's very rare. And the various bolus textures and the volumes are used. It can be slightly thick, which we make like we mix 50% weight by volume by mixing a 95% of barium suspension with a with an equal amount of water to make it slightly thick. Then mildly thick is by adding a 1/3 of water, and moderately thick is the barium suspension itself, which is 95% weight by volume. And extremely thick, we add either pudding or we add cookies to make it extremely thick. So the patient is instructed to hold the bolus, and we ask him to hold it and then ask to swallow it at once. And then the radiograph is taken, which is a continuous fluoroscopic imaging. And if the initial bolus is safe, we increase the volume as well. So we start with 2 ml in Medanta, and then we increase it to 5 ml and then 10 ml. And if the patient is not able to take even 2 ml, we try to reduce it to 1 ml. Then what are the indications? The indications are obviously the oropharyngeal dysphagia, its diagnosis as well as the management, and then to ascertain the aspiration risk in the patient with dysphagia, and to evaluate the effectiveness of various postures, maneuvers, and the bolus modification in improving the swallowing safety and the efficiency. There are contraindications, and the most important is the medically unstable, lethargic, drowsy, and uncooperative, agitated patient who cannot be positioned safely. So at times we get a request that the patient to be done should be taken for VFSS. Our main concern is the patient should be able to sit, should be in a state of mind that he should be able to follow the command also. And in case the patient is allergic to barium, then we can use a non-ionic contrast. And and extremely sick patients where the management won't be changed by the VFSS finding. These are the few of the contraindication for VFSS. Coming to the limitations, so limitations are radiation exposure, because it's not a single X-ray. We are using a continuous fluoro. So the radiation exposure is around 1.2 millisievert, but it is comparatively less compared to the CT, where it is around 7 millisievert. So radiation exposure is one of the limitation. And then it demonstrates the swallow function and not the real mealtime function. Barium increases the viscosity and alter the liquid and the food composition. This may result in the discordance between the VFSS results and the real meal. Coming to the anatomy, those who are not aware, so we can see that this is lip, upper and lower lip, and then this is the hard palate and the soft palate. This is the tongue. So this becomes the boundary of the oral cavity, and we can see the bolus lying here. Can I have the pointer as well? Pointer. So, and this is the region of this is epiglottis, this is the vallicula here, this is the hyoid bone, and this is the nasopharynx. So soft palate, this goes here and closes the nasopharynx, and this is the upper esophageal sphincter. So coming to the phases which Govathi has already discussed, I'll be just briefing you. This first is the oral phase, where the tongue abuts the soft palate and closes it, and there is a bolus, there is a mastication going on, and there is a bolus formation, lip is closed. So this whole thing becomes the oral phase, and this is followed by the propulsive phase, where the tongue is elevated and there is a elevation of the soft palate, and which abuts the posterior wall of the nasopharynx with the help of the superior pharyngeal constrictor muscle. And simultaneously there is a excursion happening. The larynx goes up along with the hyoid bone, so which is we call as a hyolaryngeal excursion. And in the pharyngeal phase, there is a this vilopharyngeal closure has happened, and there is a middle constrictor and the inferior constrictor muscle. They push the bolus further down, and there is epiglottis which inverts and closes the larynx, and the bolus is pushed down and it goes into the upper esophageal through in the esophageal phase. Now components affected in the dysphagia are lip closure, which is quite common in the MCA infarct. There is a poor lip closure leading to the drooling of the contrast. Similar is the case for the lingual control. There is a poor lingual control, so there is no good bolus formation, which is again common with the MCA infarct. And then there is a videopharyngeal closure. In this, the soft palate is not able to abut the posterior nasopharyngeal wall, which leads to the aspiration of the contents into the nasopharyngeal cavity. And important one is the hyolaryngeal excursion, where the hyoid bone as well as the larynx are not elevated that properly, leading to a lot of pooling of contrast in this region, which leads to the delayed aspiration. So this is the penetration aspiration score that the previous speaker has been talking about, which we use in most of our reports. And that depends on at what level the penetration is happening. So in case the material does not enter the airway, it is scored as 1, which is a normal. In 2, it remains above the vocal cord and is ejected from the airway. That's a 2. So these are safe. And once it enters the airway above the vocal cord and is not ejected, that's the grade 3. And this is like grade 3. And in case it comes out similar to the grade 3, but it comes out of the airway, that becomes grade 4. In 5, it touches the vocal cord and is not ejected. So, and in 6, it passes beyond the vocal cord, which becomes completely unsafe, but it comes out back. And in 7, it goes beyond the vocal cord and is not ejected despite repeated effort. And 8 is a silent aspiration, where there is no effort made to cough out the aspirated contents. So this is a video which is a normal swallow. If you see, the patient is able to take, this is a proper hyolaryngeal excursion, and there is a small amount of valvular residue which will be cleared in the subsequent swallow. Coming to the abnormal, this is a case of a myasthenia gravis which affects the skeletal muscles. So we expect the oral cavity muscles to be affected. So there will be problem with the oral phase as well as the pharyngeal phase. So if you see, in this, if you see, the oral phase is, the bolus formation is not happening properly. There is passive contrast which is going into the pharynx, and there is a very extremely delayed hyolaryngeal excursion happening, and there is a pooling of contrast. So there is pooling of contrast proximal to the upper esophageal sphincter. This is the same case with the, if you see the, there is a penetration happening now. It is going into the laryngeal lumen, but if you see, it touches the vocal cord and is coming out. If you see, it will come out, there it is. So it has come out of the airway. So this is score 4 in this case. Now this is a case of MCA infarct. You see there is a passive contrast which is spilled into the pharynx, and there is direct aspiration into the laryngeal lumen, and it is seen abutting the vocal cord and is not ejected. So this is score 5. And this is another case where we see that there is a significant pooling of contrast, and there is a penetration which is going into the laryngeal lumen, and this is touching the vocal cords here, and it's not coming despite the effort. So this is score 5 here. And these are few of the images where the contrast is going into the nasopharyngeal cavity. There is a reflux of contrast, And this is Zenker's diverticulum, where there is a outpouching at the C5, C6 level due to the mucosal and submucosal outpouching, which increases subsequently at the time of swallow. This can also lead to dysphagia. And this is the last, this is a cricopharyngeal bar, where there is a cricopharyngeal muscle which is not getting relaxed, leading to the impression and causing the dysphagia. There is associated a level 2 or the score 2 penetration also happening in this case. Thank you.
Thank you, sir, for honoring the stage.
Thank you everyone for visiting here. I hope you all learned something. Yeah, so if anyone wants to do a hands-on session, it's open till half an hour. They can do it anytime. You can learn over there. Anyone? You can go and see there. Okay, and your certificates you'll be getting at the registration area. You can collect your certificates over there. Just say that it's a dysphagia workshop, and then with your name, you can collect your certificates from there. Thank you, everyone.